Pediatric hepatology involves a wide range of conditions, but identifying the cause of neonatal cholestasis is a critical task. This condition occurs when the flow of bile from the liver is reduced or obstructed in the first weeks of life. Infants typically present with jaundice, acholic or clay-colored stools, and conjugated hyperbilirubinemia. This happens when the liver processes bilirubin, but it cannot exit the hepatic system, causing the byproduct to accumulate in the blood. This accumulation can result from two different points of failure. The first occurs at the cellular level. When these microscopic hepatic cells swell and become inflamed, they completely lose their ability to process and export bile. This cellular inflammation characterizes neonatal hepatitis. It is a medical condition that often resolves without surgery. The second point of failure is anatomical. In biliary atresia, the macroscopic bile ducts outside the liver undergo progressive fibrotic obliteration. This creates a physical barrier that prevents bile from reaching the intestine. These two pathologies, one medical and one a surgical emergency, produce the same clinical results. Advanced imaging is required to distinguish them and determine the correct course of treatment. If bile flow remains obstructed, biliary atresia leads to biliary cirrhosis and liver failure. The standard surgical treatment is the Kasai procedure. This is a Roux-en-Y hepaticojejunostomy, a reconstruction where a loop of the small intestine is attached directly to the liver to facilitate drainage. For the best results, the Kasai procedure must be performed within the first 60 days of life. Success rates decrease as the infant ages beyond this window. This evaluation flowchart outlines the diagnostic steps required to confirm or exclude atresia. Clinicians follow these pathways to systematically eliminate other causes. Because the symptoms are shared, each step must confirm the absence of a patent biliary tree. The radiologist's job is to rapidly and definitively prove a negative, the complete absence of a patent biliary tree. The workup starts with an ultrasound. This method follows ALARA principles, as low as reasonably achievable, to minimize ionizing radiation and the need for sedation in neonates. On ultrasound, radiologists look for specific markers at the hepatic hilum. This is the triangular cord sign, an echogenic region over 3 millimeters anterior to the portal vein bifurcation. It represents the fibrous remains of the biliary tree. While this sign is specific to biliary atresia, it has low sensitivity. It is operator-dependent and may not be visible in the early stages of the disease. These diagrams show how the extent of ductal obliteration varies between patients. In type 1 and 2A, the gallbladder or distal common bile duct may still be visible. A visible gallbladder on ultrasound does not exclude atresia in the higher ducts. Since a normal ultrasound cannot rule out the condition, the algorithm proceeds to a functional assessment. Step 2 is hepatobiliary scintigraphy, or a HIDA scan. This test uses technetium 99M labeled tracers to monitor the production and movement of bile. In a normal scan, the tracer enters the liver, moves into the gallbladder, and then the small intestine. Biliary atresia shows a different pattern. The liver takes up the tracer, but it does not move into the bowel, even on 24-hour delayed images. This scan has a negative predictive value near 100%. If tracer is seen in the bowel, biliary atresia is excluded. However, severe neonatal hepatitis can also prevent the excretion of bile, leading to a scan that mimics atresia. This scintigraphy scan shows the results of severe hepatic dysfunction. High tracer activity in the body and excretion into the bladder suggest that the liver cells are too damaged by hepatitis to process the tracer. To improve accuracy, infants are often pre-treated with oral phenobarbital for 3 to 5 days. Phenobarbital activates liver enzymes to increase bile flow before the scan. Even with pre-treatment, a result showing no excretion can be caused by either medical hepatitis or surgical atresia. When non-invasive tests are inconclusive, physicians use percutaneous or intraoperative cholangiography. This procedure involves injecting contrast material directly into the gallbladder or biliary remnants with a fine needle. This intraoperative cholangiogram shows a patent biliary system. Contrast fills the small caliber common bile duct at the black arrow and intrahepatic ducts at the arrowheads. It also moves into the duodenum at the white arrow, proving the ducts are open. In biliary atresia, the contrast does not fill the extrahepatic ducts and instead pools in the liver parenchyma. If atresia is confirmed, the cholangiogram provides a map of the ductal anatomy for the surgeon. A needle biopsy is also performed to examine tissue for bile duct proliferation and portal fibrosis. This combination of macroscopic mapping and microscopic biopsy provides the verification required to perform major surgery on a neonate. The biopsy also serves to rule out genetic conditions that can resemble atresia. Alagille syndrome is an autosomal dominant disorder caused by mutations in JAG1 or Notch2 genes. While atresia involves the scarring of ducts, Alagille syndrome is characterized by a paucity or a developmental absence of intrahepatic bile ducts. This MRI shows the liver in a patient with Alagille syndrome. After 45 minutes, there is no hepatobiliary contrast within the liver. Because the ducts never formed, there is no way for the liver to excrete the contrast. Performing a Kasai procedure on a patient with Alagille syndrome is ineffective because there are no microscopic ducts to drain. The biopsy must confirm ductal proliferation to justify the Kasai procedure. When biliary atresia is confirmed, the surgeon performs the Kasai procedure within the 60-day window. The surgeon transects the liver surface to find microscopic ductules. A loop of the small intestine is then attached to this area. Bile drains from the liver surface directly into the intestine, bypassing the scarred ducts. In many cases, the Kasai procedure acts as a temporary measure. This CT scan shows the long-term changes that can occur following the surgery. There is dilation of the intrahepatic ducts, shown at the asterisk, along with calcifications and a nodular liver contour. The surgery leaves the liver open to the gut, making the patient susceptible to recurrent infections known as ascending cholangitis. These infections contribute to progressive liver fibrosis. The diagnostic process and the resulting Kasai procedure function as a bridge, buying the infant time to grow strong enough for an eventual liver transplant.